Hello everyone, this is Hoor Ameen, a third-year medical student. In this video, we will have an overview about the pathophysiology of ischemic heart diseases. This allows us to understand how these diseases arise so that we become able to manage them on a clinical setting. To start with, our heart is supplied by two main arteries, which are the left and right coronary arteries. As we can see, the right coronary artery branches out of the ascending aorta and runs in a groove between the right atrium and the right ventricle, while the left coronary artery divides into two branches, which are the left anterior descending artery, passing in the interventricular septum, and the circumflex artery, which runs around the left ventricle. These arteries are considered the main arterial supply of the heart, and as you have noticed, they reach the posterior side as well, with some connections in between. However, we can consider them as end arteries, as the anastomosis between them is not really significant. So you can imagine what would happen if one of these arteries becomes occluded. So blood flow is interrupted, and hence, the area supplied by this vessel will be deprived of blood, or we call it ischemic. So this is what happens in ischemic heart diseases. Now, generally, if we want the heart to work efficiently, we need to maintain a balance between cardiac work and oxygen supply. Cardiac work is actually a parameter that can be calculated by multiplying the contractility of the heart times heart rate. Now, when a disturbance occurs, for example, a decrease in oxygen supply due to atherosclerosis, vasospasms, or anemia, or if there is an increase in cardiac work due to increased heart rate, for example, ischemia might happen. So our aim in ischemic heart diseases management is to regain this balance, and this can be done either by increasing oxygen supply or perfusion, which is not usually done clinically, or by decreasing cardiac work, and this can be done by multiple pharmacological agents that we will be discussing in another video. Now, when we say ischemic heart diseases or coronary artery diseases, we are actually referring to multiple conditions. So this includes stable angina or classic angina. We have acute coronary syndromes, which are unstable angina and myocardial infarction, and we have transmutal angina. So let's have a look on the pathophysiology of each, starting with stable angina. Stable angina is actually the most common condition. Patients with this condition have an atherosclerotic plaque, which is a subintimal deposition of cholesterol that builds up with time. Now, this will cause a disruption of blood flow through the vessel, and hence less blood supply to the area, so the area will be ischemic. A patient with this type of angina will have pain with efforts. But why is that? Let's first see what happens normally in our body when we exert an effort. So this is a normal blood vessel. Now, with increased effort, the sympathetic system will be activated, and there will be a release of metabolites that cause vasodilation. So this allows for more blood to flow through the vessel to supply the heart. But what happens in our case? We have an atherosclerotic plaque here, and it's damaging the heart vessel, so it becomes fibrotic, and this will cause an inability of the blood vessel to dilate. Hence why the management in this case will be to reduce cardiac work, and this can be done by giving beta blockers, for example, to induce bradycardia. So when the heart rate is reduced, the heart will relax and the oxygen demand decreases, so the little amount of blood that reaches the heart will be sufficient. Now, moving to acute coronary syndromes. What happens here is that the atherosclerotic plaque will be ruptured. So the contents of the plaque will leak, and this will cause a sudden chest pain. But note that the occlusion here is incomplete, and this is a classical type of unstable angina. Now, the patient here will suffer from pain, at rest, and with exertion. Now, we consider it unstable, and it needs an immediate hospitalization because at any time it may progress to occlude the artery completely, and this will result in myocardial infarction. Lastly, we have transmutal angina. And in this case, as you have noticed, there is no atherosclerotic plaque. However, all what happens is a sudden vasospasm or vasoconstriction of the vessel. It's usually associated with cigarette smoking, and it's not affected by exertion, so pain can happen at rest. Now let's see the ECG. This is a normal ECG with normal waves. You can see the P wave, the QRS complex, T wave, and everything is normal. However, with ischemia, check what happens. The ST segment here is depressed, and this occurs in the affected area. So by doing ECG, you'll get to know the blood vessel that is affected. But note that you will not always get this pattern of ECG in an ischemic patient because you are recording it while the patient is at rest. So sometimes you will get a normal ECG, so keep this in mind. What about acute coronary syndromes? Actually, here we can classify the ECG into two types: ECG with no ST elevation and ECG with ST segment elevation. So what accounts for this difference? Now, if we have a partial occlusion, it will cause ischemia located in the subendocardium, as the black area shows here. So there will be no ST elevation in the ECG, and sometimes it might be depressed. In this case, we might have two pathologies. It could be either unstable angina or myocardial infarction with no ST elevation. To differentiate between them, you will go for cardiac biomarkers. So if they were increased, this is most probably a myocardial infarction. And if they were normal, it's mostly an unstable angina. The other case is when we have ST elevation. This occurs when we have a total occlusion of the blood vessel. So this will cause an extensive ischemia, which is affecting the whole thickness of the vessel. This is called transmutal infection. And these types of infarctions will usually cause ST elevation on an ECG. So remember, we have two types of myocardial infarctions, one with elevation and one without elevation. So please, don't exclude infarctions if you don't see ST elevation. And that's it for the pathophysiology of ischemic heart diseases. I hope it was clear, and thanks for watching.